Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
Hi, I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
A 59-year-old woman who presented with cough, dyspnea on exertion, had a good performance status with unremarkable past medical history except for hypertension, hypothyroidism, and gastroesophageal reflux disease. Had a history of smoking, quit 20 years ago, no family history of lung cancer. And initially back in 2018, presented with stage 3, a locally advanced non-small cell lung cancer, adenocarcinoma type. Tumor testing revealed PD-L1 10% with a KRAS G12C mutation, underwent surgical resection with lobectomy and mediastinal lymph node dissection, followed by platinum pemetrexed for 4 cycles, followed by radiation treatment. Unfortunately, a year later, developed isolated brain metastasis treated with stereotactic radiosurgery with no evidence of extracranial progression. And 6 months later in June, she developed a second brain metastasis and again treated with stereotactic radiation treatment, and then was initiated on systemic therapy with pembrolizumab. Unfortunately, developed immune-related pneumonitis followed by prednisone, and then also had radiation necrosis of a previously radiated lesion treated with prednisone. In January of 2021, had additional progression in the brain with no evidence of extra CNS progression, and underwent surgical resection, once again confirmed the presence of adenocarcinoma with a PD-L1 less than 1%, with KRAS G12C mutation, and with a tumor mutation burden, as noted here, 11 per megabase. And imaging, do you want to comment on that, Dr. Ginsberg?
Yes, we see two metastases in the occipital lobe, one of which was a treated lesion, and the other one is probably a new lesion. And we have no further imaging beyond this section.
Thank you. So this is, again, a scenario that we have seen before, unfortunately, more than one time. A patient with metastatic non-small cell lung cancer, what seemed like an early stage, what seemed like a potentially curable locally advanced disease, and then had recurred. And then the recurrence has been dominated mostly by the brain lesion, brain metastasis with no extracranial disease, and has a G12C mutation. So this is again a very timely topic. Dr. Stinchcomb, do you want to comment on how would you approach this patient?
Thank you, Dr. Govindan. I think this is a very difficult scenario with some of our lung cancer seems to have this CNS tropism where they just keep reoccurring in the brain. And this patient has been, I think, treated with aggressive CNS treatment with stereotactic radiosurgery and a neurosurgical resection. I think the question really becomes, does systemic therapy delay or potentially prevent the recurrence of the brain? And I think historically we've thought that there was a blood-brain barrier, but with our newer therapies, particularly the tyrosine kinase inhibitors, as well as some of the immunotherapies, we are seeing some CNS responses, thinking that maybe the systemic therapy can be used to treat brain metastasis. Sotarasib, also known as AMG 510, was just recently approved this week with a response rate of about 1 in 3 and a progression-free survival of about 6 to 8 months. And so that's a newly available option. I think the question in this patient is we don't really know what is the CNS penetration, the CNS activity. If we try and extrapolate from other tyrosine kinase inhibitors like in the ALK-positive EGFR, it's a little difficult because there the systemic response rates are in the 70–80%. So you think that there's probably a good CNS penetration and good activity. But I think that would be one of the questions I would have or discussions I would have with the patient is, should you get the sotarasib therapy at this point?
Yeah, these are very pertinent points. I just would say a few things, and I'd like to get comments from others as well. Let's just quickly go over this. Unfortunately, brain metastasis appears to be a problem in stage 3 non-small cell lung cancer patient as the sole site or the first site of relapse. Dr. Keston, do you want to comment on that?
Yes. So this case, obviously the patient had brain metastases following the initial treatment. It is a common scenario, unfortunately. They were managed primarily with local treatment, surgery, radiosurgery, which is completely reasonable. Now, unfortunately, there's a second relapse in the brain in 2 locations. If it's 2 locations such as this, if it's less than 3 centimeters in size, which I'm not certain about in this particular case, then I would probably perform repeat radiosurgery. It depends on the overlap with the prior radiosurgery treatment and some other factors. But typically, with brain metastases, the primary treatment for non-small cell lung cancer over the years has been either to resect surgically if it's solitary, or to perform radiosurgery if there are a limited number, and sometimes if it's solitary, and potentially even add radiosurgery after surgery in some situations. So I could see this case at the current point commonly being treated with radiosurgery. Obviously, Dr. Stinchcomb has pointed out that there are some newer systemic therapies now that that have treatment that have effective response rates in the CNS, and so maybe some of those could be a consideration in addition.
Thank you. I would just say I would add a few more points. One is that in the days when we did not give consolidation durvalumab, if you look at the prospective studies, Dr. Vokes published this some years ago in the Journal of Clinical Oncology. Nearly a third of these patients, nearly a third of the relapses happen to be in the brain and often the first site of metastasis. Will that change in the era of immunotherapy? We don't know. We also know that immune checkpoint inhibitors have activity in the brain, and I'm presuming because it reprograms the immune system, I'm hoping that this will have some impact in the brain metastasis. And then fast forward, once you have brain metastasis, resection, stereotactic radiation therapy would be appropriate. In the absence of extracranial disease, I typically stay away from giving systemic therapy because there's not much you can follow, especially if the lesion in the brain has been radiated. But there comes a point if patients have a repeated brain metastasis only in the brain, you run out of the retail space in the brain to radiate or surgically resect, then the issue really comes, can you do anything systemically? And in terms of sotarasib or the AMG 510, when I have administered this agent as a part of an ongoing clinical trial, we've seen responses in the brain lesions. And so there is an ongoing study that is looking at only in the brain metastasis population. So that would define the activity of this agent. I just want to say it is important to appreciate that this drug is specific only for G12C mutation. It will not work for G12D or G12A other mutation. And sotarasib is a tribute to medicinal chemistry where they really identified a pocket where the G12C protein afforded a particular opening in the protein structure that allowed them to develop this drug. A number of these clinical studies are currently ongoing, both single agents as well as combinations. So this is an area that I think we'll see a lot more activity in the coming years, but it is an option potentially for those patients who are running out of local therapy options. So it is certainly an emerging and important area of research. Very good. So to summarize the issue of how do you manage patients with KRAS G12C mutation with recurrent disease, I think chemotherapy, pembrolizumab would be an option that is currently approved for patients regardless of the genotype when they have extracranial disease, a disease that we can observe. sotarasib is an option for these patients, particularly the G12C, or only the G12C, I should say, KRAS mutation. The brain-only relapse, I would think that one could watch unless you have no other option. Then I think either chemotherapy in this instance or sotarasib would be an option for these patients.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
So we've had some exciting updates, specifically in the KRAS G12C space. We finally have drugs for an alteration that was considered undruggable. The first one, of course, is sotarasib, a drug that is now approved for patients that are KRAS G12C can be done in the second line. And this is based on the CodeBreak 100 trial looking at single agent sotarasib at 960 milligrams that was given again for patients who had progressed on prior therapies. And importantly, the response rate was 37%. The median duration of response was 11 months. And if you look at the median progression-free survival was 6.8 months. And the median OS at the time of receipt of this drug, remember, this is not first line. This was given in a highly pretreated group of patients, either second line or third line and beyond. The median overall survival was 12.5 months. So because of CodeBreak 100, sotarasib was approved. This drug does have toxicities, but those toxicities are fairly well tolerated. You know, the treatment emergent adverse events, grade 3 from this study, there were 20% of these patients, but very few patients that had treatment discontinuation. The most common being because of these treatment emergent adverse events. The most common being diarrhea, nausea, and LFT abnormalities. The second study that we learned about at ASCO 2022 was adagrasib. And this is yet another KRAS G12C inhibitor. And similar to the CodeBreak 100 study, this was a drug looking at patients who had prior treatment with checkpoint inhibitor in combination or in sequence of chemotherapy. So this was a pre-treated group of patients receiving adagrasib 600 milligrams twice a day as single agent. This was a phase 2 study, the primary endpoint being objective response. And the objective response was very similar to what we saw with sotarasib. It was 43%. Remember, sotarasib was 38%. That's encouraging. Many of these responses are still ongoing. Median PFS, not that far off from what we saw to sotarasib, 6.5 months. Median OS, not that far off from what we saw with sotarasib, 12.6 months. Perhaps this drug is a little better tolerated from sotarasib. Again, diarrhea, nausea, LFT abnormalities seem to be the most common, but a pretty well tolerated drug. So I think based on this, at least in August 2022, that we will soon have an approval for adagrasib. Right now, sotarasib is the standard, but we may have another option in our therapeutic armamentarium, making it very exciting right now to treat patients with advanced non-small cell lung cancer.